off then. Thank you everyone and welcome to March Health in Hackney. I have had apologies for absence from John Williams and Malcolm Alexander from Health Watch Hackney, Councillor Spence and Laura Sharp, who's just received a new batch of vaccinations, and so she's processing those. Can I welcome Helen Woodland, who's the new Group Director for Adult Health. Welcome, and also congratulations to Anne McDougall on her promotion to Director of Adult Social Work and Operations. Congratulations to Siobhan Harper and Tracey on the new roles in ICP, and I understand they'll be joining us later. Can I just remind everyone that we are in PERDA, so please refrain from any political comments. The usual matters of housekeeping. This is being recorded, press are watching, it's being live streamed. Please keep your microphones on mute, only unmute your speaking. Members of the Commission, please keep your cameras on. Please don't start conversations in the chat other than just to indicate you want to ask a question. I haven't been notified of any conflicts of interest or declarations of interest. So with that, I will move on to item number 4 on the agenda, which is an update from the Vaccinations Steering Group. We heard an interesting informative presentation at our last meeting on this, but we very much appreciate a high degree of hesitancy amongst our community, and so we it's appropriate to keep a spotlight on this issue. We're grateful to Dr. Stephanie Coughlin, who's the chair of the Vaccination Steering Group, Graham McDougall, who's the Senior Programme Manager, Siobhan, who will be joining us shortly, and Alice Beard from Hackney Communications Team. I understand, Stephanie, you're going to take it off, and then I think we've got some slides. So we've got half an hour for this item, and I was hoping for presentations in around about 10 minutes or so, and then opening up for questions. Stephanie, over to you.
Yeah, thanks very much. And yes, those timelines absolutely fit with what we were thinking. We wanted to allow as much time as possible for discussion and questions. So first of all, say thank you very much for inviting us here today. My name is Stephanie Coughlin. I'm a GP in City and Hackney and clinical lead for the CCG on COVID-19, and as part of that, the vaccination programme. So we thought it would be helpful, following on from the discussions that happened last time, that we would give a bit of a brief update on where we are now in terms of uptake and vaccine confidence, and I'll lead on that, and then hopefully Siobhan will be able to join us in time, and then Graham and Alice will pick up some of the elements that I know everyone's very interested to talk about in terms of engagement work and the work that we are doing with our communities. So if we could go into the next slide. So what we thought would be helpful to talk about is a bit of a stock take on where we are to date. So if we look at our uptake rates across cohorts 1 to 4, so those are, most of the cohorts are based on age, and then as you get into cohort 4, that incorporates clinically extremely vulnerable, so we are at 75% uptake. And then looking at our cohorts 1 to 6, which cohort 6 includes some of those you might expect to get an annual flu vaccine, with some exceptions as part of that, we are up to 69%. And I think one of the important things we really wanted to get across as part of the presentation was really the sort of continuing efforts and the continuing progress we are making week on week across the cohorts. And whilst this, what we've presented here on the slides, combines the cohorts, and so the overall progression, when you start to dig a bit deeper into the data and you look at some of the cohorts that we've been specifically targeting and increasing confidence amongst those, so our cohort 4 and our cohort 6, I think what's been really impressive across March is that we've had week on week-on-week increases, which have ranged from 15 to 28% across March, week-on-week increase. And I think that really demonstrates the progress that we are making across the board. And I think it's also really important to say that this is a combined system effort. And this is health, social care, LBH, City of London, public health, community champions, voluntary sectors, and other interested community members really pulling together to engage with our residents and patients about how we can increase confidence for the vaccine. A bit of an update on where we are in terms of our local sites. So we have our 2 local vaccination sites, which I'm sure many of you will be familiar with, John Scott in the north and Bocking Street in the south. And I'm really delighted to say that we are expanding our community pharmacy sites. And I think this is a really, really positive. And we've been fortunate in City and Hackney to have a larger proportion of pharmacy sites than some other comparable areas. And whilst that slide says that we're up to 4, we're now up to 6 sites as of Monday, and by the week beginning the 3rd of May we will be up to 7 community pharmacy sites, and so I think that's a really, really positive addition. Homerton and Barts have continued to be hospital hubs whose predominant focus has been on staff vaccinations, and there's continuing offers for first vaccination. So we're at a point now where with our cohorts 1 to 9, where we're moving from doing just first doses to now doing first and second doses together. So actually, the 2 different priorities: how do we continue to engage with those who where we need to increase confidence, whilst also being able to provide second doses at the same time, and making sure we're getting that conversion with the second dose uptake as well. So as I'm sure you can appreciate, huge amounts of work going on behind the scenes. So we move on to the next slide. So this is what I talked a little bit about before, and actually we're starting to track this data in this way, in a much more targeted way, so that we can identify the impact of the work that we are doing. And I think that's really important to understand when we make concerted effort on a specific cohort, that we can then see impact of that work. And I think from this, the week-on-week changes here, particularly at the start of March, I think really, really fantastic. And what's been really good to see in cohort 6 is that actually week on week on the 18th, 25th and the 30th, we've actually maintained a 7% increase across cohort 6, which I think is really, really good. If we move on to the next slide. What we've tried to do here is that I hope everyone can see this okay, but what we've tried to do here is recognising that there are some differences in vaccine confidence amongst our community, and using ethnicity as one of those markers to be able to understand where that confidence, where we need to work on that in a more targeted way. So what we've done, and actually we've only seen this data presented in this way today, is we've mapped here broken down by ethnicity, the different ethnicity groups, which are tracked in the sort of blue bar chart, which tells you what percentage of those populations have been vaccinated. And then what the red dot tells you is what is the residual absolute number of residents and patients that still need to, that we would ideally want to be uptaking a vaccine. And seeing, as you will see from this data, our Black African and Black Caribbean communities are those where the residual numbers of people still to take an offer of a vaccine is much greater. We knew this already, but I think what this really helps us is to give us some objective data which maps this more, and then also this allows us to think about this on a much more local area. So we aim to do some geographical mapping on the basis of this to support that engagement work and then the outreach work. And I think one thing that the teams across the system have been working really hard on is having our communities driving that engagement. And Alison and Graham will talk about this in a lot more detail now, so that we get that engagement in place, and then that leads us into really targeted and successful uptake of vaccine. And I think it's important we consider success in a much broader way than just an uptake of a vaccine. And so actually, success is how do we reduce the impact of COVID for our communities. And actually, yes, uptake of a vaccine is one of those, but you may also think about testing and people wanting to do lateral flow testing, or people starting those discussions through generations are also successful markers. I see Siobhan's joined us now at this point, so probably now's a good time to bring in Siobhan before then Graham and Alice talk a bit more in detail about the engagement.
Siobhan, are you okay to take over then?
Yes, I'm so sorry I was late. I was just getting back on the train. I was just slightly disorientated because are we talking? Did you?
So I've done the update, Siobhan, and then on to you now, and then over to Alice and Graham to talk about
the detail. Okay. Okay. So I guess building on what the last bit I caught of what Steph was saying. Yeah. I mean, our program is, it's embedded and it's running well, and I think our focus really now is on uptake as one measure of success, I guess, as Steph has outlined, but being much more strategic in our approach, really, and really looking to engage the whole system in our partnership effort, really, because we recognise, I think, that this is not something we can do on our own. From a health perspective, we really want to work more holistically across the partnership, and with our voluntary and community sector partners in particular. We have, I mean, Alice and Graham will go into a bit of detail around some of the detailed plans that we have, but we are obviously targeting vulnerable communities in the sense of people who are homeless, or people who maybe substance misuse users, or other initiatives around people who are unregistered, etc. So we are trying to be as far-reaching as possible in our approach, but I think we do recognise that we need to deploy a number of additional initiatives. Really, now we're getting to that stage where we still have quite a significant cohort of people within the 1 to 6 target groups who remain unvaccinated. And from a population and public health perspective, that's a concern. And so it's really trying to regroup the partnership into, and our colleagues in primary care, obviously, in terms of a focus on how we reach those people and discuss in a reasonable way concerns that they have about vaccination, and get them to a space where they feel positive and more confidence about taking up the offer. We are. I think it's important to note that we are obviously under a lot of national and local attention around this, and our uptake rates are drawing attention, and so we are very cited on that, and we do recognise the importance of this for our population, in the sense that we want to protect people as much as possible from the harm that COVID, we know, can cause certain groups in our society. So it's really, really important that we engage with each other on this. But I'll let Alice and Graham talk a bit more in depth about some of the specific initiatives that we're working on.
Thanks, Siobhan.
I'm conscious of time. Alice, do you just want to give a brief update then on slide 5?
Yeah, of course. So obviously we're working as a local system on this. So there's a task and finish group which meets every Monday, that consists of a member from each of our partner organisations. And we have this week submitted a bid for additional funding from NHS England to support our outreach work that we're kind of already doing. There's a lot of work that's already underway, but as Siobhan says, there's a need to kind of ramp that up a little bit. So there's a bid that went in this week which kind of covers the following that I'll run through now, and we're due to kind of run these activities across the next 2 to 6 weeks, maybe kind of going a bit longer than that, but ideally in the next 2 to 6 weeks we'll run a series of outreach work. So we've done a number of community vaccination clinics already. We have done a number for our Haredi community. We also had an event last Sunday for our Black communities at Bocking Street. But I think what our main focus moving forward is really making that community-led. So we have a project underway at the moment with Can and Swim, and I know Peter at the last Health and Hackney committee mentioned about the work that they're doing. So we now are officially working with them, and we have vaccination clinics booked in for the week commencing the 12th with support from the Cllr vaccine team, and they're taking place at the Pembury Centre. We've also got a pop-up at the North London Mosque on Friday the 9th of April. So this is before Ramadan starting on the 12th of April and is following Friday prayers. And then we're also looking for additional clinics for other communities, including our Turkish Kurdish community and our Chinese communities. But the way that we're going to plan for these is really based on the insight and uptake data. So the ethnicity data we now have that Steph walked us through earlier is really, really useful for planning those community vaccination clinics. We've also got a walk-in clinic at John Scott on Sunday the 11th of April. So this is for all eligible residents that fall into cohorts 1 to 9. We're also opening that up to undocumented and unregistered residents. So we are not requesting them to be kind of signed up to a GP. We'll be encouraging them to register with a GP, and we'll be able to do that for them on the day, but that will not prevent them from having a vaccine on the 11th. Additional community conversation events are also taking place. We have one tomorrow for our South Asian residents. We're looking into setting up an information bus, which will kind of travel through the borough, and we're working really closely with our community champions on that to provide support. So we'll be looking at different locations based on the uptake numbers, and also maybe looking at places of worship where there's a large proportion of some of our communities kind of congregating at certain times during the week. Door-to-door visits, so we're working with the local authority colleagues and adult social care services on this. So we're looking at how we could potentially get some of our staff to knock on doors to a number of residents that have not responded to their invite. There's a number of things we're also working with, obviously with our primary care and GP colleagues. So we're looking at how we could provide additional resource to our clinicians and care navigators in relation to the telephone calls that they're making to those that haven't accepted an invitation yet. And we're looking at how we could work with the voluntary sector on that as well. And then finally, we're looking at how we could potentially mobilise a mobile vaccination team. This could be through a bus or through another route, and focus on high density social housing estates. And what we'd really like to do with that is vaccinate from a multi-generational point of view. So if there's a household that we identify that might have not as much confidence as others, then we would vaccinate the whole household at that point. And then we're thinking of doing a refresh on the comms campaign, and we're working really closely with the team at LBH and City of London on that. So that's both for residents with a particular focus on our communities, so making sure we've got all of the information translated and working with our community champions on that, but also looking at what we could do for our care sector. So obviously that's a lot of information there. Sorry if I've spoken really quickly. There is an appendix that will be coming around after this meeting, which gives all of this in more detail, but that's just a bit of a quick overview of what we're doing at the moment.
Thanks, Alice. No, and thanks for these this presentation in particular. That was very helpful. Just before I open it up for questions, I mean, how much is this that you need extra funding in terms of, I suppose, in what an ideal world you would have everyone on that residual list you would want to focus on, and in an ideal world, I suppose a GP would carry the most weight, and you'd have a GP calling around every single one in a chronological fashion and doing that. I mean, do you have that level of funding to do that? Is that where you would want to get to? How constrained are you on that?
Shall I answer that one? So the bid to NHS England is it's a good sum of money, and we've been given a positive indication that we are likely to receive that fund. So I think, but I think capacity and resources are an issue when you're getting into a very dispersed model or a very outreach focused model. And it's something that I think we will have to consider as these proposals become more developed, and the money that we get from NHS England, if we need to supplement it, I think we would, as a CCG, or as a partnership locally, and as part of NEL CCG, we would want to make the case for that as required. And I mean, obviously the Excel support, etc., is not, we don't have to pay for that support. That's funded, extra capacity that can come into our local system. But the difficulty with some of that is just the negotiation. It takes time to organise, and having our own resource that we can deploy more effectively, I think is probably potentially a more effective way forward. So we're hoping to work up that model if we can.
Okay, thanks, Siobhan. Questions from members? Any?
Hi. Yes, I have a question.
I've got Councillor Gregory.
Hi, thank you for the update. Please, can you advise us what we're working towards in terms of a target with all these extra measures? So we're looking at 69 to 75% take up at the moment, but what's the figure we want to reach? Is it something like 96, 97%? And also, how long do you think it will take to reach that target? Because obviously, whilst there's such a high percentage of people who haven't been vaccinated, then the kind of risk of local spread increases compared to other areas and other parts of the country. So yes, so when will we reach a higher target? And do you think the measures that you're planning to undertake will deliver those?
Maybe I can answer some of this. So there is a national target, which I think has changed a couple of times, 92.5%, I think is my understanding. So a target of around that figure across all of the cohorts. And I think to answer your question around when will we reach that target, I wish I could give a concrete answer to the question, but I think for us it's really seeing that week on week improvement throughout all of the cohorts and seeing the impact from the work that we're doing. We think that the sort of scope of the engagement work that Alice has walked through is comprehensive, and I think we are learning from each of the events that we are doing. We are continually learning, adapting, and changing things. And I think you made a really important point around the more we can vaccinate and the more uptake we get of vaccinations, the ongoing reduction in broader impact of COVID we can have across our populations. And I think thinking about some of the discussions we had at the Vaccination Steering Group today, actually thinking ahead to the autumn and the winter, and I think one of our targets is really to be pushing up towards that as we get towards autumn and winter time, when we can expect there to be potentially, we don't know all of this as yet, potentially further surges, which will have as it currently stands, a disproportionate effect on our populations and the services which we as a collective partnership provide for our populations. So I think as we move ahead, we really have autumn and winter in our mindset now. I hope that answers your question as much as we can, Stephanie, at this point.
Thanks, Stephanie. I see Councillor Snell. I'll just come to Councillor Snell in a minute. But just building on that in terms of the in terms of how you're looking at the data and you're sort of seeing the week on week. Are you seeing a week on week increase in the residual numbers of, say, Black Caribbean who have the worst, say, uptake at the moment, and are you looking at that? And I suppose if all the focus is, say, going into certain community groups, you'd want to see an above average level of uptake in those groups. So are you cutting the data to that level?
Yeah, so this is the first week that we've been able to look at the data in this format. So absolutely, week on week, we will be looking at, as I said, the impact of the events that we are doing. And whilst we might wish that we could break down some of the ethnicity data even further, particularly one of the other areas that we've highlighted is the ethnicity, people who describe themselves as other white. We've made some assumptions about who these communities might be, thinking about our Eastern European community, thinking about our Orthodox Jewish community. But now, yes, absolutely, we're going to be in a much better place to be able to track impact of the engagement and then some of the outreach work and guide that. So that would be what we would looking at. And as I said before, just that feeding in, that learning from the events. I think the events that we've already done so far, we have learnt from and we have adapted into the future events that Alice has talked about.
Thank you, Stephanie. Councillor Snell.
Well, thank you, Chair. I continue to act as a volunteer 2 or 3 times a week at vaccine centres. I mean, such is the army of volunteers that this week, when I guess vaccine supplies were down, all the vaccine centres were sort of full of volunteers within about a day of the places being put up. So I'm this week just doing pharmacies, because people don't like working on their own pharmacies. And the pharmacists can generally cope without volunteers, but is outreach, and it is reaching, I think, a new clientele, because a lot of those pharmacists have an existing relationship with their staff. If I just say, the biggest thing I took away from the last of these meetings, and I've been using it when I've been on reception with people trying to choose between vaccines, was, I think, Mark Rickets, I hope I'm quoting you right on that, saying, look, I'm in charge of this programme, and I don't know, and nobody will know for the next 6 months which is the best vaccine. And I say, so if the leading doctor in Hackney is saying that, trying to pick between vaccines is a pretty stupid thing to do, so just get in there and get it done, you know? I'm a little more subtle than that, but thank you very much, Mark. I think that's been a very useful thing to pass on. When we come on this one, the problem we're getting at the moment, and what I liked about the papers that came to committee tonight, is we're getting a load of people turning up. Oh, we hear there's leftover vaccines. We hear we can just drop in and get a vaccine and all that sort of thing. And as I understand it, the reality, so and we talked about this at the last meeting, there's a load of people out there desperate to get vaccines, and we're not going to compromise our ability to get vaccines through the national system by being too generous. But for example, there was a teacher who turned up and she'd been off school when her school got one of these extra groups that we did when we started doing the special needs schools and all that sort of stuff. And we needed to tell her, you know, go back, speak to your head teacher, he can allocate it. So the problem to some extent to me at the moment is managing people who want to get vaccinated and are, you know, coming up to vaccine centres thinking that there's some free-for-all. So that idea, yes, we have specific groups that we are looking after. We need to be clear about that, and we need to advise those people so they don't get frustrated and feel they're being cheated. Other people are somehow doing better. And I'd be interested. It was in the papers, so thank you very much for that. The other thing that I was interested in, and I think you said it, Alice.
Just quickly, Councillor Snell, can I ask you just quickly, because I've got a few other people wanting to come in as well.
And the thing I'm interested in, Alice, is you talked about, I think, the fact that people are monitoring our success in Hackney to find out how we are getting to these groups. And I think it may have been Siobhan, actually. We have been relatively successful. I'm just interested in hearing, are we going to be seen as a model of best practice? I mean, how are, and who's interested to learn, and where are the areas I think we can teach other places?
Do you want me to quickly respond?
Yes, please. Yeah,
is that helpful? I think your first point, I'll be quick. We've tried wherever possible to work in line with the JCVI cohorts in City and Hackney, because that that has been the national mandate, and it is very difficult to prioritise one single disease specific pathway, just using that as an example, over another. So we have maintained consistently that we follow the JCVI. And then your other point, I think, is very welcomed around actually how can we demonstrate best practice. And I think using the example of the work that we've been doing with the CAM and SWIM networks, I think would be a really good case study that we could share, because that is absolutely driven by the communities. So I think, Alice, that's something we can take away and think about how we share that across NEL, and then how we share that wider.
Great, thank you, Stephanie. I'm going to take the next two together, and then I'll come to Mark at the end. So Cllr Plouviez, then Cllr David.
Thanks, Chair. Thanks for the presentation. Given the importance of care homes and hospitals as potential sources of COVID infections nationally, how are we doing with the percentage of workforce vaccinations in both those places?
And before you come in, Stephanie, Cllr David?
Yeah, thanks, Chair. Can you hear me?
Yep.
Yeah, okay. And thanks for the presentation. Just two quick things I want to raise. The first one is, how are you arranging, or should I say designing the message which is going to go out on those, should I say, campaign buses or vaccination campaign buses going out into the high population areas, because if you get the message wrong, that could be counterproductive. And then secondly, on the issue which Peter raised, I think that's something which there has to be a balance struck. So if we're saying we want to get as many people vaccinated as possible, and then there are vaccines left over and there are people who want to come and have vaccines taken, and we're saying, well, you know, you can't come and take it. Sometimes it might be just that one moment which someone decides, well, I'm going to come and take the vaccine, and if the person gets disappointed or turned away, that could just put the person off. I was going to have my vaccine. It was I was called to take mine, and the time I wanted to book, I was unable to get it, and I just, well, okay, I'll leave it until, you know, when I have the time. So sometimes a balance has to be struck on that. I don't know, is there a way you're going to address that, or is it just going to be strictly, you know, kind of? So those are 2 points I have to make. Thank you.
Thanks, Councillor David. Mark, am I okay? I'll bring you in at the end if okay, Mark. So if I go to Stephanie first, and then I'll come to Mark.
So maybe if I could, I'll respond. I don't have the up-to-date workforce data right in front of me, but from just having a quick look back through some of the previous steering group minutes, so workforce is categorised in 2 ways. One of the ways that we're looked at is in terms of our CQC registered care home workforce uptake rates, and then we have more general workforce targets. In terms of our care home uptake, we are comparable to some of our North East London colleagues, but we're not at a place where we want to remain with our current uptake in care home registered staff. From the last data I have, we are at 58% of staff being vaccinated. So I think there is work to do there, and we've been working closely with LBH and City of London on this. So I think there's work to do on those aspects of it. And I think linking to the other point on how do we make this easier, this is where the event on easier to access appointments, the event on the 11th of April will be highly publicised as a walk-in and as a drop-in, and we're also going to use that event on the 11th to understand what was the barrier that people found that meant they didn't access one of their other invites, and so actually they've come to that drop-in, that walk-in clinic. So we're going to use that event on the 11th both to hopefully make it more accessible, but do some of that insight work as well, so that then we can learn from that and understand what barriers are out there. But I'm happy. I don't know if Graham, you want to come in about the workforce one.
Yes, just to say, I think in terms of care home staff, I think we're doing well. In terms of home care provider staff, I think that's where we have significant issues. So we've been focusing our discussions with Chris Lovett on home care providers and their staff, and so they're doing a piece of work with those home care providers to try and increase, you know, the confidence that then moves through to uptake of a vaccine. So it's easier in care homes. It's been better in care homes. We've still got some joint work to do with the local authority in terms of home care provider staff.
Thanks, Graham. Mark, and then if I can, Councillor Adams. So Mark, do you want to come in next?
Just a couple of things. I'm sorry if I missed anything because my internet just suddenly dropped off from the house, so I lost it. I lost you all for a minute or so. But just a couple of things. One is about the reciprocity of learning from each other. There's lots of innovation going on across North East London, and actually, you know, we have got the sort of work that Steph alluded to is something we can share. But we're also finding out lots from elsewhere, and that's been really, really useful actually. Learning from one another. And I think the other thing is just to talk about the rate of people who are at the moment declining, and actually how you manage that, because you don't want to sort of give up on people because we believe in this, but at the same time you can't keep ringing people who say, don't ring me again, I'll come to you when I want it. If you ring me any more, I've had colleagues, GP colleagues, have been told that if you ring me any more times, I'm going to put in a complaint. You know, so actually sometimes it can be quite forceful like that. So if you look at the cohort 2 patients over 80 years old, there are 5,161 patients there. 81% have been vaccinated, but 13% currently have declined. Now that's, you can only record that as declined when you've had at least 3 attempts to persuade someone to come to a vaccine centre. So, you know, but actually we know that when you vaccinate somebody and you have a conversation and they say, well, my family told me not to come and I've done it, you congratulate them on their courage. And you also, I always take a moment to say, you know, can I take a photograph of you doing it? Do you do social media? Can you spread the good word? And actually that peer-to-peer does change people. So some of those declines are still coming down. This outreach work will come down. They'll still get the occasional phone call and you'll say, I'm sorry, you know, if that's the case, or you have another conversation because they've moved on. But I think if you add some of those figures together at the moment, it appears we're doing a bit better than, you know, because there's an awful lot of work going in, but you can't force people until they're ready to have it. So I think, and we know that those decline rates and caution rates are much higher in many inner city type of communities. And then if you add the number of people who maybe their mobile phone's been cut off, they haven't got one, they've moved and their address is now wrong and you can't contact them. It just adds to the sort of complexity of the challenge. But the challenge has been described. How you're trying to meet it is what we're trying to do, what the others have said. So I just wanted to give a bit more context, but actually not to diminish the efforts, just to give the context, really.
Thanks, Mark. That's very helpful. We're slightly running over, so I'm just going to quickly take Cllr Adams, and then I'm going to draw this to a close. Can I ask others to lower their leg?
Thank you, Chair. Yes, there has been. Thank you, Chair. Thank you for the presentation. There has been some speculation going around that there will be some. There will be a fall in the vaccine supply next month. If that happens, will different vaccine be mixed for people? And secondly, I'm just wondering if you can actually tell us a bit about the effectiveness of the vaccines against the new variant. Thank you.
So I think, just picking up on the first question, I think the first thing to say is that all second dose vaccines, all the supply is already badged and guaranteed. So anybody who's had their first dose is guaranteed supply of their second dose with the same vaccines. That's the important message. I think the other important message to get across is that anybody who wants a first dose in April will be able to have a first dose within Hackney and the City of London. The London team and North East London and the regional team have guaranteed that we will continue to have some first dose supply across the weeks in April. So I think those are 2 other quite important messages to get across. In terms of the new strains, I mean, the research and sort of phase 4 trials, as you might call them, once the vaccine is rolled out, are continuing to evolve and be looked at. I think one of the really helpful early evidence that's coming through is that both vaccines, regardless of whether it's Pfizer or AZ, have a massive impact, a hugely positive impact on hospital admission. So actually those who have had a vaccine, and there's some very helpful graphs out there which show the percentage who are currently being admitted to hospital or have been admitted who have had one vaccine or no vaccine. And I think the really important message is at the moment, regardless of the strain, we know that these vaccines have a significant impact in reducing severity of illness from COVID. I think we can expect some booster doses in the coming autumn and winter and going forwards, which will incorporate much more of particularly the Brazilian and other strains which have a certain mutation in them, which is common amongst the different strains. So I hope that answers your question, but the evidence is continuing to evolve. But I think what's really important is around that hospital admission and severity of illness, which I think is a really, really important message to be getting across.
Thanks, Stephanie. Thank you all for this. It's great to hear what's going on. I think certainly from where we were last month, to see a far more sort of targeted, data-driven and complete approach going on is very welcome to see where we are. So thank you very much. I mean, just one observation from, I think, something that the initial presentations about how we don't necessarily see vaccines as sort of one measure. I suppose one thing I immediately thought when that was said was, well, because we're not doing so well, are we trying to move the goalposts? So I'm sure that wasn't necessarily it, but it could be perceived as that. That was something something that went through my mind. So I just maybe just give that feedback as to how you present that going forward, because it could be construed in the wrong way, I think.
Yeah, thanks for the feedback. I'll take that on board. I think one of the things I'm very conscious about with this messaging is that the hard work that the community groups are doing, I don't want that just the numbers of vaccines that they deliver in an outreach programme on the day in a particular place to be deemed as the only successful measure and the only measure of success that the community engagement and the really hard work that the communities are doing are measured on. So I think that's more where my messaging is coming from, recognising that I want people who have put huge amounts of effort into this, regardless of whether they vaccinate 11 or 55, actually I want them to understand that the hard work that they have done in terms of those discussions with the communities across the household is successful. So I think it's more around, but I think I'll definitely take that feedback on board to how I frame that differently next time.
Well, thank you all very much indeed. That's wonderful to hear, and I think we'll keep it under review as to whether, I think certainly when the prevalence rates were going up, we had Sandra Husbands with us sort of every session. It may be we don't need all of you, but maybe we could ask one of you to come back next time to give us an update. Thank you very much. Please don't feel you need to stay for the next items, so please feel free to leave the meeting. Thank you very much indeed. So with that, I'm going to then move on to item number 5, which is the Population Health Hub. We're very excited to hear about this. I understand it's been something that Dr. Husbands has been championing along with Jane Taylor, who's our consultant in public health. And I think we're with Jane here tonight. So Jane, can I hand over to you? We've got probably about 25 minutes for this, so maybe a sort of 5-10 minutes on the presentation and questions. Thank you.
Okay, shall I share my screen for the Population Health Hub bit? It might be easier to talk through. Would that be okay?
Yeah, please, if you can. Can you do that? Have you got access to? Yeah.
I hope it'll work. Let me just have a look. Yeah. So, can you see anything?
Yeah.
Good, great. Let me go back to the beginning. Okay, so we're in the very early stages of the Population Health Hub, and I'll try to make clear the link with the Health Inequalities Steering Group that's also been formed recently, but we are in the early days of both, so these things are likely to change a bit. So basically, you'll be aware that we previously had a prevention work stream as one of the 4 work streams driving transformation as part of the integrated local integrated care system. And in summer last year, Sandra took a proposal to the Integrated Commissioning Board to recommend that we dissolve the prevention work stream and create a new population health hub. So the idea was that prevention really needs to be embedded across the system more, but actually there's more of it needs a broader focus, the population health, which I'll come and explain in a minute, but that incorporates prevention, incorporates mental well-being as well as physical health, and it really includes a really big focus on health inequality. So I'll come and explain that in a moment, because there's a model that we're using, which is referred to here on the slide, is that so both the Health and Wellbeing Boards in both Hackney and the City, as well as City and Hackney Integrated Commissioning Board, adopted this population health framework. So it's really good news, because we've all adopted the same approach, and I'll come and explain what that is in a minute. Also, it references here the Health Inequalities Steering Group that is setting a set of strategic priorities for tackling health inequalities in the wake of COVID, but has a longer term focus as well. So that's what the paper is, just setting out our initial proposals around this. So just to set as a context, I'm quite happy to come back to this. I won't spend ages on this, but some of you may have seen the King's Fund Population Health Framework, which basically says that in order to really improve health across the board and tackle inequalities and really improve community wellbeing, we need to take action across these 4 what they call pillars of a population health system. So the wider determinants, I think things like your income, employment, housing, education, our health behaviours and lifestyles, smoking, alcohol, diet, etc. Really importantly, the places and communities we live in and with, and and obviously an integrated health and care system, but that being just one part of the picture. And we are really recognising that in the work that we're doing around integration locally. So this was quite a useful framework for us because it sort of articulated what we're trying to do. And what the model basically says is you should be balancing investment across all these 4 pillars and really focus attention on the areas of overlap where you get your biggest bang for your buck, essentially. So I can come back to that if people are interested. So this just sets out the purpose of the proposed purpose of the Population Health Hub. So it's to be a shared resource across the system, and I won't go into all of the detail, but it's essentially, it's a bit long-winded, but it is making sure that we've got very timely and actionable data and insights, and that we've got some very practical tools which help to influence and support wider partners to improve population health and reduce health inequalities. So it becomes embedded in everything we do. We are working through the governance of this, but it does have a very important role as an enabler within the new integrated care partnership, and that is still being, I think there's an agenda item about this later, so we can talk about that as part of that as well. So these are the proposed functions of the hub. So there's a strong focus on using data and insights and evidence and research. And I think the balance between the actual hard data and the community insight is really, really important that we have both of those, because we need to understand what matters to people. And then a big focus on using quality improvement type approaches to improve our services and to really focus on prevention and improving and reducing inequalities. And then a whole load of tools to enable us to do that. So this goes beyond the sort of traditional just doing equalities impact assessments. It's actually thinking about how our sort of thinking is shaped, like in all of our decision making on a day-to-day basis. I won't go into detail of this, but this is just to say there's a lot of resource and infrastructure out there that we can actually draw on. So we're not starting from scratch. It's about how we pull all of that together, both locally, North East London, and nationally and London level. We've started to map out the resource requirements and where that might come from. So some of these posts and resources are in place. What we're doing at the moment is trying to work out where we get some of this other resource from, and we've started conversations with both Health and Wellbeing Board, Integrated Care Board, and other various groups and leaders to identify that. I won't go into detail on this, but I'm happy to come back to it. So this is not my area of expertise that I lead on, but we use this as an example for how we can actually use a population health approach to improve outcomes and to really support us with the work that's already underway. And this is an example from the Neighbourhoods programme. Again, I'm very happy to come back to and answer questions if I can on that. There may be others on the call who know more about this than me. So that's it on the Population Health Hub. Shall I pause for comments and questions on that, or shall I go straight on to the Health Inequalities Steering Group, Chair?
I think if you could, how long would you take to go to the Inequality Steering Group?
I can do that in 5 minutes because I haven't got a presentation. So shall I just do that?
Yeah, no, then please do, and then I'll do the whole lot of questions together. Yeah, yes, please.
Sorry, I seem to have lost my sorry, yeah, right, okay, fine. I'll do this quickly. So basically the paper, let me stop sharing my screen. So the paper that you've got, basically I'm just going to summarize it basically. So it's really clear that COVID is acting as a catalyst for local action to tackle long-standing health inequalities. That's no surprise to anyone. And the Health Inequalities Steering Group has been convened to provide a focal point for the work that's going on locally. There's a lot of work that's happening. So this is just to make sure that we make most of our sort of collective efforts and resources. The steering group membership is drawn from across the 2 local authorities, voluntary sector, various NHS organisations, and both City and Hackney Health Watch, and it's chaired by Dr. Husbands, our Director of Public Health. And we're developing at the moment our approach to involving residents in the work so that we have a really meaningful way of engaging and involvement of residents rather than just a tokenistic having a representative on our board. But we're working on that with Health Watch, HCVS and others. The steering group has met 3 times, twice twice in workshop sessions to quite rapidly develop a set of strategic priorities for mitigating the longer term inequalities impacts of COVID. So there were 10 broad areas for system-wide action that the steering group has prioritised, and it's going to lead on 4 areas where it felt that by providing that leadership, it would actually sort of increase the impact of the work that's underway. So a lot of stuff around improving routine collection and analysis of equalities data and insight to inform action, having the right tools, as I mentioned, and resources in place to enable routine consideration of health equity and decision making, tackling structural racism through a real partnership position and action plan, because there's a lot of work, a lot of pockets of very good work being done on this, and then work around strengthening our work on community engagement, involvement and empowerment, and building trust. I probably will stop there, but just to say that the aim of the idea is the steering group will advise and support the development of the health and wellbeing strategies, both of which are being developed for Hackney and City this year, and an integrated health and care plan for the Integrated Care Partnership Board. And obviously we'll be working really, really closely with the Population Health Hub, who will be sort of like leading on delivery of some of these priority actions. And just, I would say that over time, I think the work of the steering group and the Health and Wellbeing Board will increasingly align. And so we need to keep under review the role and scope and purpose of the steering group, because hopefully at some point we won't need a steering group leading on this, because it'll be what we just do in our day jobs. So I think I'll just stop there if that's it.
Thanks, Jane. That's fascinating. Exciting to hear about the work of the Health Hub. I mean, it strikes me if I've sort of conceptually got it right, that this is going to be a resource for everyone in the system to be able to use, up-to-date resource that's constantly mapping and evolving and advising. But then, you know, to what extent are you going to get buy-in from the rest of the system to actually implement it in a meaningful sense, and how does that part translate? And how are the conversations going with everyone else to make sure that when you come up, say, with a recommendation, or you see this really needs doing, it gets driven through into real action?
So that's exactly the conversation that we're having over the last couple of weeks. So we've only started really presenting the scope for the Population Health Hub in March. There's people on this call who have been involved in discussion, so they might want to endorse their support for it. But the initial response was very, very positive. So maybe Siobhan wants to add to that. She's got her hand up. That's
Siobhan's just raised her hand. Yeah. Siobhan?
Well, yeah, I mean, I would just completely...
You might be on mute, Siobhan.
Oh, can you hear me now? I can hear you. Yeah.
I've got you.
Yeah. I would just completely endorse what Jane has presented. I mean, we've been talking about population health and health inequalities for, you know, some time in health circles and in joint planning circles, etc. And I think this just gives a real focus and a real emphasis that we can really make use of, and it really kind of, we certainly want to embed it in our ways of working in our system, and how we take things forward in the new arrangements, which we'll be talking, Tracey will be presenting on a bit later. But I guess the other thing just to say as well is that certainly health inequalities are really much more front and central even just late in the recent planning guidance that's come out from the NHS nationally. You know, there's much more of a expectation about that being addressed. And whilst, you know, you can have a degree of, you know, words it's actions, not words at the end of the day. But I think the fact that it's there is quite a big step. And I think that we're really well placed by having both these forums happening for us locally to, you know, to really drive some change, I think would be my take on it.
Thanks, Siobhan. Members, questions? Peter, Councillor Snell?
Thank you, Chair. There were 2 reports there, basically, and I want to ask a question on each. Before I retired from working in public health, there was a whole network of health observatories that generated all of this data. And I'm interested in how this is fitting in with that wider support network that came under Public Health England. I mean, am I completely out of date and that's all been scrubbed away? Because obviously if we can use it, we should use it. The second question, and this slightly feeds into the next item agenda tonight, is the people who were leading, it wasn't really my area, the people who were leading on feeding public health concerns into the NHS felt it was absolutely crucial that when GPs or primary care people were identifying an issue that could be affected by environmental factors, they would then have the computers that would say, oh, and what sort of house do you live in? Do you have damp? Do you have the other issues that we know feed into bad health? I'm partly warning the people who are introduced in the next item that that's what I'm going to be asking on that one. But do we have a system in primary care that picks up associated environmental factors? Because that is so critical to getting extra investment and extra help to the people who need it most.
Jane?
So maybe Mark or Steph might be best placed to answer one of those questions. But on the health observatories, they don't exist as they once did. But PHE do have a really strong intelligence function. Unfortunately, we're not quite sure where that's going to end up with the new public health structures that will be in place later this year. But we have just heard that the Office for Health Promotion will be established alongside the what's it called, Health Security thingamajiggy. I think where that intelligence function sits is to be confirmed, but absolutely we need to make, because there's some really excellent resources there that when we do make a lot of use of them, so we don't want to duplicate that effort. I think in terms of, interestingly, with the conversations we've had initially we've got a couple of GPs on the Health Inequalities Steering Group, and one of the things they have actually talked to me about is that sort of the value of being able to, if you've got having a conversation with someone and it's clear that something else is impacting on their health, it's like, how do you, having the tools at your fingertips to be able to do something about that. And we obviously have social prescribers and other community navigation roles that will help with that, but actually having some way of, recording some of this, so that can actually be acted upon, or then that information is known to the wider practice team. I don't know, Steph or Mark, whether you wanted to actually come in on that from a sort of practice perspective.
I mean, I would just,
Mark,
I haven't got much else to add. It would be hugely, sorry? It would be hugely valuable to have that level of information. Sorry, I should have said it's Mark here. Yes, but I can't really add any more to what Jane said. It's a work in progress, really. And we do have the sort of the promise of data sets coming from, say, the discovery data set, which I think probably has been discussed here in the past, which is the clinical effectiveness group in QMW, who's got doing some remarkable early work in terms of pulling together information from all sorts of sources in ways that we haven't done before, and mapping that on postcodes and even streets and things. But it's a work in progress. So yeah, it will be very valuable if we can get that right. It's an ambition.
Thanks, Mark. Councillor Plouviez.
Thanks, Chair. Just going back to the presentation, and we hear a lot in health about rising needs, and I see here anticipatory care. Just for me, could you give me an example of what that is? I mean, you've got somebody who hasn't yet developed 2 or 3 long-term conditions. So, assuming you could identify those people who might, who does the work to stop that happening?
So I think that's what I might invite somebody else to sort of, because I'm not very close to the detail of this work, but the idea of that is that you would use the data to be able to identify the cohorts, and that then leads you to work out who is best placed to actually do that work. And so I think primary care is really important because we have all sorts of data on, so things like people like smoking and body mass index and all sorts of other risk factors, you know, it is possible to have to do a bit of stratification around that and to identify cohorts of people who are at risk of future ill health, or who may have, you know, sort of low level. When I say low level, that's really poor shorthand, but who haven't developed severe illness yet.
Sorry, I don't want to interrupt, but I didn't ask you what the conditions were. I asked you who was going to come in and fix them.
Okay, so this is the whole point of this is what neighbourhoods are about working together to bring all of that together so that we respond as a system. So it's not just like one person. I don't know if I'm struggling because I'm not involved in the anticipatory care in detail, so I don't know if there are other people on this call who can actually answer this question a bit more articulately.
An example that's not. I mean, if it's just an example and difficult, then that's fine.
I've got our new director who's just put up a hand, and I'll come to Siobhan.
So I think Jane was doing a good job really of describing what our neighbourhoods programme is working on, and the answer to your question really is whoever's best placed. So that's why we're looking at multidisciplinary teams and approaches. So it might be a combination of people. You might need an OT, you might need a GP, you might need a social worker, it might be our voluntary sector colleagues who are actually best placed to provide some support, or it could be a combination of all of those people. But by having them grouped together in a team with all of that information, we can deploy the resource when we need it, where it's most effective.
Thanks, Helen. And Siobhan, did you have anything else to add?
No, I think Helen's covered it really. I think it is just that's the bringing together and then deploying the most appropriate person. But in the pursuit of avoiding a deterioration or a exacerbation, you know, and there's obviously going to be levels of intervention, because, you know, whether you're talking about a primary prevention, which might actually just be a one-to-one intervention with a GP, rather than a secondary prevention, which might be more of a joined up approach with, you know, trying to limit the harm that somebody's going to have from their long-term condition, but they've already got it, if you know what I mean. So it really depends on what you're aiming for to some extent.
And is the funding going to be there for this? I mean, as I understand it, the problem has always been sort of with a prevention workstream or whatever. I mean, the system is geared towards financing the firefighting at the back end. So, well,
there is a significant investment in the neighbourhoods programme that's been agreed again this year. So that's been in place. I think this is the third year, I think, of investment in developing those models of care and those ways of working. And obviously we have quite a lot of existing resource. We have a major contract with our primary care clinicians around long-term conditions management in particular, which does do a lot of that interventionist kind of work with people in pursuit of certain measures that will be preventative around certain conditions. So we've got some really quite established building blocks that we can use to consolidate, I think, in a more proactive way. And then obviously the PCNs are getting resource for the anticipatory care contracts too, nationally. So there's lots of other capacity in the system, like community navigation or social prescribing, all of which could form part of that anticipatory care offer, really, to give people that intervention earlier, so that they're treated earlier and then don't become more of a crisis admission to hospital further down the stream. Really, that's the ambition, I think.
Thanks, Siobhan. Helen, was that a legacy hand, or do you want to come in again?
I think it was Siobhan's really answered the question, but probably just to add, it's also about redeploying some of the resource that we've got more effectively. So making best use of what we've got, as well as the additional resources that are being invested.
Thank you. Thank you all. I mean, that's truly fascinating to hear the work that's being done there, and I think it's something we'll want to hear more about, maybe in 6 months or a year's time, to see and particularly if you can measure milestones or any outcomes that have arisen from that, and to see where we're at. So thank you very much. I'll draw that item to a close, and that nicely brings us back on time. And Jane, thank you very much. Please don't feel that you need to stay for the rest of the meeting. So thank you very much for coming and for those presentations. I'm now going to move on to item 6, which is termed Digital and Remote NHS Services. And we're very grateful for Jenny Singleton, who is, I don't know, is the CCG still in existence, Head of Quality at the CCG. And so she has prepared a fascinating presentation in terms of learnings and recommendations. I'm very grateful at page 12 of the report, she's got a list there of 15 very specific recommendations. So Jenny, again, we've got about half an hour for this item. So if you can speak for maybe 5 to 10 minutes, and then I'll open up to questions. Over to you.
Sure. Yeah, thank you. I'm trying to turn on my camera, but I can't seem to do so. So what I'll do.
Right.
Yeah.
You see bottom right.
Yeah, no, it's
icon there.
It won't turn on. I tell you what, I'll try and come back in. Hang on.
Fine.
Yeah. Apologies.
No, Jenny, because we're on you now, we can hear you. I may have lost her. Temporary pause while.
So it's still not working, is it? No. Apologies,
I
don't want to hold it up. Yeah.
Fine, Jenny.
So thank you for asking me to come along. So I'm the Head of Quality at City and Hackney CCG and have been for many a year. And the background to this paper is I was asked to look at, it was digital services, but when I sort of started investigating this whole area, it seemed to me that we actually were talking about remote services, because many of the services we've referred to as digital are actually a mix of telephone, virtual and face-to-face. So really we want to talk about remote, and I think that's how patients and service users see that. And so you've got a long paper, sort of a discussion paper that's part of the meeting papers, which where I've looked at remote services in terms of the sort of quality framework that is generally used in the NHS, and that is patient experience. What do patients feel? How do they experience those services? And how we involve them in those services and improving them and measuring how good they are. Safety. So there's a bit in there about, for example, safeguarding and IG and security in terms of digital services, and then quite importantly, outcomes, and what do we know about outcomes in terms of what these services may deliver as compared to face-to-face services, because what we want to make sure is that they deliver the outcomes at least as good as we know that they that face-to-face services do. So in the sort of PowerPoint paper, I've tried to sum up sort of the main thrust of what I found, which is largely that remote services offer people an amazing opportunity to take more control and be more involved in their care, that they're loved and liked and valued by a lot of people. But as with everything, there are some unintended consequences, and there are some issues that we need to make sure that we look at as a system when we're developing these services going forward. And in particular, we need to recognise and mitigate some of the inequalities that potentially can occur in relation to who can use these services and how people feel about these services, so that we don't exacerbate or increase current inequalities even further. And there are some assumptions made, and I'm trying to very much avoid them in these papers, about who likes these services and who likes to use them and whether they have a good experience with them. So sometimes we think about older people, for example, being less keen on them and less able to use them and feeling locked out. And that's not always the case, but there is a clear kind of, from my point of view anyway, there's a clear message in a lot of the literature that that people need access to cheap Wi-Fi and devices, and that's not always available to them. That there are some implications for safeguarding residents in terms of how they use these services, and whether they have the space and the opportunity to have private conversations at home and so on. And also that some of these services are seen as being imposed on patients rather than being developed with them, and that we could do better, I think, generally speaking, to join up some of the work that's taking place so that it's easier for patients, carers, residents to use these services, to get the digital skills to be able to really feel comfortable using remote services. And we must recognise that this is not always appropriate for everything. And then finally, there's a bit of an issue about what staff feel about using these services. So, you know, the NHS is about people, and if we don't develop these services with staff and ensure that staff are comfortable and feel competent and safe and can continue working in teams, which is really important, that we will increase the stress and anxiety and what's the word? Feelings amongst staff that they are that have come apparent during the pandemic, and we need to make sure that staff are supported and involved in developing these services. So I guess just to sort of give the overall message is that I think we as a system could do more to work together to join things up a little bit more, and to make sure that we have patient defined outcomes, and that we measure patient experience a little bit more as we go forward, because this is the direction of travel. It's a national sort of direction of travel as well as a local one. It's a necessity during COVID, but it won't go away. It will develop as we go forward. So
thanks, Jenny. That's really helpful. I can see Councillor Gregory wants to come in. And just before she does, I mean, what's the resource? I appreciate there's probably quite some resource going into the patient record side of things, but what's the resource within the city and Hackney to essentially see through your recommendations and to help GP practices develop their websites in a more accessible way? I think when we looked at this a few years ago, I think Tower Hamlets we were quite impressed by. I think they had a GP on at least half a week sort of focusing on this as their job. I mean, do we have that level of resource going into coordinating the IT landscape across City and Hackney?
That's a very good question. In some ways, I think it's not necessarily resource in terms of money and so on. It's about bringing people together and working as a system rather than as individual organisations. There is quite there's fairly substantial funds, I understand, in the IT Enabler group, and other people will know more about that than me. And certainly, I think there's an open door within the IT Enabler group to do more to involve service users in taking forward that programme of work. And again,
I think resource may have been the wrong word, I suppose leadership. I mean, you know, going around the 40-odd practices, look at each website in turn, thinking, hang on a minute, that needs improving, let's help you, that's okay, that needs improving. Going around all the hostels methodically, thinking, okay, we can put in extra resource. That level of methodical approaches, I suppose, is what I'm talking about, to start putting this into practice.
Yeah. Well, for me, it's not necessarily about doing it on a one-to-one basis. It's about developing a framework where we can develop these services within a framework which says patient experience is really important, and patient-defined outcomes for these services are really important. And this is the sort of work you can do to enable that to happen. So we wouldn't be telling practices, for example, we think you should use X to provide your digital offer. We would be saying, if when you're developing these services, what we would expect is that they would have baked in patient experience data, and that data would be shared and looked at, and we could bring it all together into one place, and we could look at it over time and see what people are saying about the care that they're getting remotely. Do you see what I mean? So I don't think it's looking at in each individual website. It's about trying to support practices to think through the implications of how they're developing their services remotely.
Thanks, Jenny. Councillor Gregory.
Yes, thank you for that. Very interesting how the digital offer has panned out in the pandemic. But I just wanted to know what practices are doing for people who cannot, particularly elderly people who cannot even use a touch tone phone. And who become very disenfranchised, for example. How are we reaching out and keeping in touch with people so they're not feeling more isolated and in effect forgotten about? So if they can't even use a touch tone to make an appointment to the GP, how are we supporting them? Are the GPs going to go and do more home visits to compensate for people who can't access the online services? I'm very concerned about these hidden groups of people who may just be forgotten about. Or will there be regular contact, like regular letters? Hi, how are you? We haven't seen you for a few years. Just wanted to check in on you. People who don't necessarily have access to looking at the internet and website and receiving updates, like a lot of people now get texts from their GP surgery. So I'm very concerned about those people who are out of the system. Could you explain a bit more about that, please? Thank you.
I think we temporarily lost Jenny. Are you back there?
Yeah, I'm here, yeah. I've got really good Wi-Fi.
Sorry.
I just wonder whether Mark might be able to help me out in that case. He's got his hand up. So
yeah, Mark.
I think practices were still, although there is this enhanced remote offer, as it were, which didn't exist sort of 5 years ago, it isn't completely replaced all the things that used to happen. So you can still phone your practice in a conventional way, and you can still, now it is, practices were never shut during COVID. They were just, the footfall was sort of managed and reduced. So you can still walk up and ring the doorbell if you have no access to any sort of phone, but can get access in the same as it always was the case. And practices do sometimes do searches on people they haven't seen for a while and see what's happened to them. And as a CCG, we have commissioned enhanced services over and above what GPs get paid for their core work, to do proactive home visiting to those who are known to be housebound, and they would get a number of pre-planned home visits a year. Now, they would be in addition to any additional home visits somebody might need because of an acute problem. So, and there's also an enhanced practice-based kind of reviews, clinics in all manner of different ways for people who've got cancer, or people who've got long-term conditions, or people who are just frail. So that all that is also there and has been augmented. And those sort of services have existed, were well established pre-pandemic. So the pandemic of those has affected the way everything works. We are, increasingly getting back to ways of being which were pre-pandemic.
Thanks, Mark. I mean, I think I've raised it before. I mean, I've raised Michelle's point before. I think not so much during the period of the pandemic, but certainly before, where there was, I think, a greater emphasis on the practices to provide so many of their appointments online. I mean, I had a number of councillors from different wards, different areas coming to say that they've had residents normally elderly residents who finding it difficult to get access to an appointment. So that, you know, that has been historically a continual feedback, and whether I hear what Jenny says about, you know, individual practices giving them the tools, but I mean, part of me would still like some sort of, I suppose, structure across the piece where residents just know that they can get through at 9 or 10 and be able to answer, and we're not getting this feedback that there is problem on getting access and getting through.
Just to say that some elderly people I know cannot even use a touch tone because they're partly deaf, and they can't even get through to the GP even on the phone nowadays. It's because it's all, you know, you need a certain amount of understanding of technology. So it's not just about the pandemic.
I'll come back to Mark maybe in a second, but can I take Councillor Snell first?
Yes, I think Michelle's points to some extent are valid, because as far as I can see, quite rightly, on the VAX programme, it's overwhelmingly gone out via phone and text. And my 93-year-old mum said, well, I'm not used to being told what to do on the phone, but she did turn up. And clearly, she never managed to cope with a smartphone. And I guess that's the area I'm concerned about, because I am aware that GPs, primary healthcare, has been overwhelmingly relying on the phone system because the post has been so useless. And I realise this report, I think I'm making a point rather than asking a question, and it follows on from you know, my last comment. I realise this report is primarily focused on the community engagement with the digital system. It does worry me, though. The sort of holy grail of every primary care person is prompted to ask a question about your living conditions, your housing, who you live with, are you under stress from the people you live with, which would then trigger involvement from council support services, is what we should be aiming towards to support the initiatives that came up on under the previous item on the report. And I look here on page 6 of the written agenda, and we're operating on 4 different systems. And so the idea, we could do a simple fix across the piece to say, okay, you're going to be prompted to pick up on these issues, that environmental issues that might be affecting your health. It's not possible about 4 different systems. So my question, and I know it's not the focus of this report, but it would surely be a hell of a lot better if we can move towards a single system. And given the wonderful work the Confed has done in bringing services together in the past, it's achievable.
Mark, do you want to pick that up, or?
Are you referring to a single system for sort of remote access, do you mean? So the online?
I'm suggesting that if you're recording records of patients, then it would be good when someone comes to a consultation with you that they have something that prompts your concerns about their social circumstances or their environmental circumstances, and that you can then record that on the system. That means you can then pass it over to the public health colleagues at the council. And what I'm suggesting is that it's very difficult to think about that when every practice is using a different system.
Certainly, the way that we sort of come around when there's an issue, we often develop. All practices record their patient records on a system called EMIS, and that's completely linked into the clinical effectiveness group again, which I mentioned earlier. And they, when we commission, generally it's via the Confederation, who then commission with practices, and that allows us to do sort of whole population approaches to these things. We talk to the clinical effectiveness group, and they design things called templates, which pop up if you write a certain condition type in the notes. You are prompted to use these templates. Well, then on that you will have information. Enter here you know, is this person a carer? What is their name? What's the contact detail? What, you know, is there an issue about housing? So we can do that and record it. There's always a pushback that in all these situations, there's always that. I guess it's the old triangle of quality, capacity, and access. You know, the more that you say we could do more in a consultation, the fewer consultations there will be to spread around, unless you have more capacity. Which you don't have more capacity, you need more doctors and nurses, you need more money to employ them and more places for them to sit and more computers. So there's always this dynamic kind of balance which you never get to satisfy all 3 points simultaneously. I mean, as we said before, you know, City and Hackney do have some of the best ratios of GPs and nurses per 1,000 patients. And actually, compared with, I mean, I suppose it's scant kind of compensation to know that it could be a lot worse and more challenging elsewhere. But bit by bit, we have built an offer in primary care, which by and large is good. And when there are patterns of a practice where the telephone system really is not functioning properly, they just don't have enough people picking up the lines, we want to hear. And either the CCG will have a conversation or the Confederation will, depending on what the circumstances are, to try and understand why, try and support and remediate is always the first approach. You know, when there's a sort of consistent issues coming up. So it's always good to feed those back to us. But I'm not going to pretend that every time everyone's experience of primary care is always perfect. But there are hundreds of thousands of consultations going on all the time. So, you know, there's about 1 million per week across England. It's a lot of activity, and I wouldn't pretend that it's always perfect. But we always aspire to making it as good as possible.
Mark, how are we still?
Great to hear that, Mark. Can I just say, all I was making the point was, can we make the technology as simple as possible?
Yeah.
Can I just throw into the GP Confederation that you monitor a load of performance in different areas, and actually finding out how many people use that follow-up screens that say you can record wider circumstances would be a good thing to monitor, and then help the people who aren't using the further screens, and that has to be fed into the engagement process that we talked about earlier. So
yeah. No, and I think the point is well made, because we could probably do more in that space actually about recording people's actual housing, for example. Yeah, so it's a good point well made, and take that away.
Mark, are we losing? There was a point maybe 1.5 years ago when I think, if not a bit longer, we were sort of quite closely monitoring how many patients we were losing to Ask My GP. I don't know how that's been affected by, or similar providers, how that's been affected by COVID. I mean, where are we? Is there still a concern there that that's destabilised them, or has the potential to?
I have to admit, I've been asking to see those registration data for a while, and we were getting it, and for some reason it's become more difficult to get. But anecdotally, I understand that people are still registering with them. But for some people, the enhanced online offer that is now with us post-COVID has, you know, is very popular with some of the people who otherwise might register with those such groups as that, who of course don't offer all the other services that we do in mainstream primary care. So we need to get back to you with an up-to-date figure on that, I think.
Thank you very much. Members, any further questions before I bring this item to close? I don't think there is. Jenny, thank you very much for that, and for the specificity of your recommendations. And that, you know, it's obviously something we're going to want to come back to track progress going forward. I mean, my overarching thing is however you term it, in terms of leadership or resource or just direction, in terms of one person that's holding the ring in driving all this forward for the best interest of the borough. I'm still not 100% sure that you know, having listened, that's necessarily in place at the moment, but that's just my observation. You know, I don't know whether that's fair or not. But Jenny, I think your evaluation it was fantastic. Thank you very much.
Thank you very much. And I guess this is work in progress, really. And this is not going to ever stop, really, now, is it?
Yeah. No,
it's a bit like when we introduced telephones, you know, and there were worries about people that didn't have a phone, and we had to try and shape things around that. And so I think this is just going to be ongoing work, but we're probably in the right place to do that now. So, you know, the immediate response to having to do remote services is fairly declining. But the other thing to remember is that for some people these are better services, you know, and that's not just talking about the people that, you know, find it easy to access services. So one of the most interesting things I think I found is that people with poor English often find some of these services better for them. So, you know, we must be aware that there are benefits for certain groups that may have been marginalised before in terms of these services, and you know that there's a lot of good in kind of envelope, as well as some risks and issues that we need to be wary about.
Yeah. Indeed, and I think the overall view of the committee is that everyone that wants to be able to use these services to be able to use them seamlessly, to have the best access they can. But for those that, for whatever reason, are on the wrong side of the digital divide, or however you frame it, to still be able to gain easy access to their GP through other mechanisms, I suppose. So I suppose it's that twin process. Yeah. But Jenny, thank you very much indeed.
Thank you.
With that, then I'll bring this item to a close. And Jenny, please don't feel you need to stay. Thank you very much.
Thank you.
And then with that, we'll go on to the last item, which is the new governance structure for the Integrated Care Partnership. And we've got Tracey here and Siobhan and Mark. They've got a helpful presentation with lots of flow diagrams in the agenda pack. Welcome, Tracey. We've been enjoying the new green wall at the Homer this week and all the pictures of that. So that's been great to see. I don't know who's going to start the presentation with respect to the new system. Is it over to you, Tracey?
Yes, I think so, Ben. Thank you for your comment on the green wall as well. I take it you've only seen it in pictures at the moment as opposed to in real life. So hopefully by the time it's settled down, it'll be something that we're using as a something using as a live memorial, really, for the year that's gone. Right, okay. So firstly, an apology, and then secondly, something I say at every point in which we discuss this. So firstly, this is the first time I've presented on this. Normally I sit and happily listen to David describe it, albeit obviously I've been heavily involved in the discussions around it. So I apologise, I'm a bit rusty, and no doubt Siobhan will dust off any rust that I leave. And the second point is, which I always make, Tracey, and it's twofold really. This is a journey. Hello?
Oh, sorry, I've got a slight lag. Tracey, I should have said to the fellow members. Oh, can you hear me now?
Yes, we can hear you, Ben.
Yes, very.
Sorry, fine. I had some lag. Tracey, sorry, I should have just said to the fellow members that under the new system, you and Siobhan are the new David in terms of taking up that leadership role. And I should have, in some way or form, I should have just introduced it that essentially you're now taking a more of a leadership role across the whole system. And so that's why you're presenting in this capacity now. Sorry, that was my fault for not giving it that introduction.
No, we actually have a slide in that trying to explain that. So I wonder who is then anybody. Alice, are you able to show the slides? I don't know who's. I
don't know if she's still here, Tracey.
Not on the call, Tracey, we've got them on the agenda pack. We've all got them.
They are printed, yeah, they are printed.
So we can see them, and so we can see the first one for the City and Hackney local system. and the second one with clinical leadership, and the third one with resident involvement. So tell us which one you're looking at, and then we can go there.
Yeah, so I'm going to have to do it off the top of my head because I can't see you and see the slides because of the way that Google Meet works. But that should be okay on my computer. You can only.
I can share it. I'll present it, Tracey. Yeah,
gosh. Sorry, this is not a good example of my first presentation on the system side.
Quite honestly, Tracey, someone who's come to the whole of this meeting without a word to say so far, showing a degree of dedication that I absolutely love. So you don't have to apologise to me.
Yeah, well, I'm in a learning mode at the moment, Councillor Snell. Who I did see you cycling you passed us on. We were in the car and you were on your bike cycling vigorously through Hackney. I was very impressed with the speed.
You're not allowed to say you're in your car in Hackney anymore.
Oh, sorry. I was in Catherine Pelly's car, actually. We were going to St. Leonard's. I was not on my Brompton. That was in the boot of the car, unfortunately. Whoever said...
Jonathan, are we nearly there?
Yeah, bear with me. Hold on.
There, can you see mine?
Yeah. Chris, thanks. That'll do. Right. So as Ben's already explained, and we come on to this at one of the end slides. My day job to date, as I think most of you know, has been Chief Executive of the Homerton. As of, I guess, tomorrow officially, I become the leader officer for the ICP within City and Hackney. Siobhan is picking up the Director of Transition within the CCG for the next 6 months, recognising that although we've known about the shift from one CCG in City and Hackney to a North East London CCG and the development of a ICP system, of course, these things will take some time to work through. So there is almost a degree of movement from a sort of old way of working into hopefully what will be a new way of working. But I would emphasise that is going to be a journey that we'll probably be working on for months, years to come. And the second point I usually explain associated with that statement is what you see in front of you now is possibly going to be different in a year's time. And I don't say that because I know that. I say that because inevitably there'll be refinement and we'll better understand how we want the system to work across City and Hackney as we come together as partner organisations. So this is very much a learning curve, and a pretty steep learning curve for all of us. And I suppose finally to say that there isn't a blueprint that's available from elsewhere, and to some extent City and Hackney are at the sort of sharp end of the development of this way of thinking, and certainly are locally within North East London, and so therefore we're making some of this up as we go along, and there's very little to draw on from elsewhere at this point. Having said that, given some of the changes that have been heralded in within the operating plan that's just been recently published, and what's likely to come through with the new legal changes, then we know that these sort of changes are going to be happening across the country. So I think there's a benefit for City and Hackney to stay ahead of the game on this. The very practical, Joel, if you just leave that slide there. Actually, sorry. The very practical, because people tend to like to gravitate towards a sort of structural diagram, although the boxes and arrows sometimes lose the sense of working together and collaboration and relationship building. But this is the governance structure that we're looking to establish from this point onwards. The City and Hackney Integrated Care Partnership Board is is a familiar sounding name. It's a slightly expanded name, and in doing that, it's the intention is to expand it to include provider organisations as well. To date, it's been more of a commissioning board, and as part of the development of the system, what we really need to think about is how, in effect, do we all become commissioners? Do we all think about how do we best use the City and Hackney pounds that we have, and that we retrain ourselves from the way that we've been operating over the past almost 20 years probably, where there has been a sort of distinct split between commissioners and providers, and there has been a sense of people and organisations being more out for their organisation as opposed to managing pathways for the populations as best as we can do collectively and jointly, even if that's a compromise within your own service area. And I think the point was made earlier, right, when you were talking about neighbourhoods and thinking about how they work, and I think Helen described it very well. Some of that coming together of teams that currently cut across individual organisations is part of what we're trying to create as this system, and the vision and where we're going with that is really going to be set at that Integrated Care Partnership Board, in which all
Tracey, just
have a
there. Who's going to sit then? Can you just tell us who's sitting on the Integrated Care Partnership Board?
It'll be chaired. So the series of councillors, members, and then chief officers from the individual organisations plus a non-executive. So a range of officers and non-executives on that board, but also weighted heavily with members from both the Corporation of the City of London and local London Borough of Hackney.
Thank you.
The City and Hackney Neighbourhood Health and Care Board is largely going to be the sort of operational engine room, or the executive engine room, to make sure that we are formulating delivery plans and streams of work, and making sure that we're doing that in a way that really focuses on ensuring that every development is including the population and representatives of who we're trying to provide services for, who we're thinking about pathways for. So that's really the sort of, if you like, the executive group, and that in that group will contain chief officers from each of the partnership organisations and a central system team. So the really interesting part about, I think, this move is how do you get to a point where you really do get, for example, your finance individuals coming together and really thinking collectively about not only how do we manage the system finances overall, but how do we think innovatively with regards to how we best use resources across the system, and having a system finance lead who really coordinates that is an example of what one of the system team members would be doing. One of the first appointments that I'd want to make in that team is the ICP clinical lead. So again, not somebody who would necessarily be managing everybody, because of course we have individual sovereign organisations. I'm part of one of those. ELFT is another example, and there's an awful lot of GPs and PCNs to think about. But how do you create a role where somebody is really facilitating and influencing and coordinating and bringing together those groups to throw challenge into those discussions, but also to help facilitate those discussions as well. Some of the groups below, you'll see familiar names, and there is something about making sure that we don't drop anything during this process, and inevitably will understand better how, for example, an ICP finance and performance group will work in comparison to how finance commissioner provider finance meetings have worked, and also the finance and performance meeting has worked in the CCG to date. And how do you really bring that together as in a system way of working? And I know that will take some time to work through. I think what's really important, and the one thing I do really like to emphasize, is that the real work and the real thinking about how do we best improve services for patients, how do we really think about how we tackle the health inequalities at a very local level or a very pathway related level, really does happen within the boxes that are highlighted in grey. And of course the intention would be to bring together members of the population, members of clinical teams or service providers who are involved on a day-to-day basis, who really do understand where the issues are and where the benefits are and where the duplication is, to really give them permission collectively with representatives from the population to rethink how we could do things better and differently. And I think one of the key things that I really try to get over is there's quite a lot of focus and gravitation towards something like the Neighbourhood Health and Care Board, but actually my view is all of the work and the thinking and the influence really should happen within those quite local pieces of work that are highlighted in the grey boxes. And I am not somebody who works in a clinical service. I don't work with families within Hackney, but there are an awful lot of people who do, and there are an awful lot of people who are better placed to understand what we're not doing as well as we can do, and what we're dropping between organisations, or what we're duplicating between organisations, and really already have a cadre of families where they already have relationships with and can understand better how we could better serve those families, for example. So I guess I see my role, the system team role, and the Neighbourhood Health and Care Board as a structure to make sure that we're empowering and enabling those people who are better placed to understand those nuances, and to create an environment in which we can really drive through change. And of course, what is important about having chief officers on that Neighbourhood Health and Care Board is there's something about, an example would be the Homerton representative taking a decision back, taking a consensus decision back, and making sure that we play our part. The Homerton plays its part in delivering that, even if that is a real shift in how our teams have worked, or the Homerton teams have worked to date. The only other thing I want to highlight in this as well is making sure that we retain heavy involvement and really valuable involvement from the primary care contingent within City and Hackney as well. One of the things that I guess we don't want to lose or drop during the transfer between a local CCG into a local system is that engagement, because I know that vast amount of our activity, the significant proportion of our activity, is currently received within primary care. And if we're going to stay in a relatively good position in the way that we have been to date, then out of hospital services are the way that we're going to be able to achieve that. And the second thing I want to highlight is the People and Place group, which is really important. It probably, I'm not so sure the name quite describes it as it's intended, but this is building on making sure that we have absolute understanding of locking in people, population, families, individuals into our thought processes, and that should be providing not only expertise and knowledge, but also challenge to make sure that when we're considering either changes or new initiatives, or the way we're thinking about the health of our population, or the inequalities of health in our population, then there's always that challenge, and make sure that we're checking back and we're not going down a sort of statutory mindset route, but actually we've always got that challenge at coming through the system to make sure that happens.
Thanks,
the next
Tracey.
couple of slides.
Tracey, just before you go, Tracey, I think there's a bit of a lag between us. Just before you go on to the next slide, how are you going to ensure that the Integrated Care Partnership Board doesn't just become a rubber stamp and is actually a sort of a meaningful accountability body?
So I guess there's two things associated with that. One is, in my mind, there is a process, and there's almost an annual process of ensuring that the challenge is set to the Neighbourhood Health and Care Board and the work streams that are going to exist for the forthcoming year. And one of the things that I think the Integrated Care Partnership Board is really key in doing is setting that vision and those challenges for the forthcoming period of time, and holding the Neighbourhood Health and Care Board to account to deliver on those. So I see it less as a rubber stamping and much more as a challenger, and that as executive officers we're making sure that we're delivering on what was almost, you don't like to think of things in annual cycles, but sometimes it's easier to think of them in annual cycles when you're talking in this context, that you're setting out your aims and your vision, and what we should be doing within that system team is establishing a route map and a plan to be able to come back and deliver against some of those visions. Otherwise we just set visions and we don't actually make tangible differences in what we're doing. So I think that's much more than rubber stamping in my mind. Ben, I'm conscious I've talked quite a bit actually, and I'll try and just whiz through the last couple of things.
Whiz through the next thing, then I'll open it up. But I think this is a useful sort of information thing for members. So I'm probably less concerned than I would be about your members' questions. But quickly go through, and then I'll open it up.
Yeah. So just the next couple of slides really are quite easy, and I won't go through them in any detail. But they're just they're quite a neat way of describing to people like yourself, but also different groups, as to where either clinicians will interact within this structure. And of course there's a need for us to make sure we do not lose that clinical voice within City and Hackney, which is all power to our arm, if you like. And the one thing that we also need to make sure that we're doing, and I'll probably be a constant challenge in this approach, is if we're really talking about system, then we're really talking about clinicians and practitioners across the board as well. And again, that's part of the shift from a commissioner and provider arrangement to who are the clinicians and practitioners who understand this issue or understand this area of work and need to come together. And there's nothing ever more interesting than getting a set of GPs and a set of secondary care type of consultants, irrespective of whether they're from ELT or Homerton, and asking them to solve a problem. And inevitably, after a while, you'll get there. But of course, within out-of-hospital services, you're actually not just simply talking, and you shouldn't be just talking about medics, you're talking about a whole range of professionals and practitioners, and including in the care sector as well, who undoubtedly get delivered from us in the secondary care sector things that could actually be delivered in a much better way for a better outcome for those individuals that we're all trying to look after currently in our own way. And the question is how can we currently look after them in our joint way? So that's the clinical leadership roles. And then the second one is how do residents get involved in this structure as well? And of course there is an absolute need for us to make sure that we're doing that, and we're doing that with meaning, and not necessarily just doing that to say it. And now, of course, that is much easier to say than do, and to make sure that people really do feel that they have got representation and involvement. But that's not to say that we shouldn't keep working at that. and that's got to be a key focus, I think. We then come on to, in the last couple of slides, which you'll have access to, just some of the outline of the roles and responsibilities of the ICPB and the Neighbourhood Health and Care Board as they've been defined at the moment, and you'll see in that hopefully some of the things I was saying earlier in the difference between establishing vision, really the challenge to the system, and then the accountability of the system to really move and deliver on some of that. And then finally, the final slide is well, perhaps what we should have put first, actually, Ben, is some of the transition arrangements, both in terms of committees that we need to just continue working with for the time being, because we don't want to drop anything, and they have a very valuable role and have had a very valuable role for several years now. And then the transitional arrangements with regards to both myself, Siobhan, and also Mark, who now has I'm sure he can speak for himself, but has a very interesting role in bridging the North East London CCG and City and Hackney, of which myself and Siobhan will also get embroiled in that as well. So this is, as I say, this is the structure I think we will be looking to work with. I'd never say that's not going to change, because I think there's an awful lot we need to learn. And one of the key things I think that we need to do, two key things I think we need to do now over the next 3 to 4 months is start getting that structure working and in place, if you like, and active, and those meetings happening, and a beginning of a formulation of what the agendas are for that. And then secondly, beginning to start pulling together and establishing a system team as well, who will help begin to facilitate some of this, because as committed as we are, this is not jobs for single people. This is a real movement across the board, and it needs to be much wider, and that's the aim. And having some more dedicated people to be able to help with that would be imperative, I think. So that's about as much as I'm going to say.
Thank you, Tracey. Thank you very much. If we can take the slide down, just gives me a better view. Thanks, everyone. Right, members, quick questions if I can. I see Helen's hand up, but any members before I bring, or is that Mark's hand, actually? I think, Mark, is that a legacy hand?
No, I was just going to mention just one thing, actually. You asked...
Go on, Mark. And then
no, just a quick thing, if I might, because just when you asked about the Integrated Care Partnership Board, being more than that tick box, how you described it, don't forget that within there is embedded the local area team, the local area subcommittee of the NEL CCG board. So that's where our allocation of money and the connection is key with our CCG board, which is the NEL CCG board. Now we're at one place. So it speaks to Tracey's point that I kind of bridged that. So that's where that is managed within the system, and of course that will give the ICPB a lot of heft in those kind of planning and decisions and accountabilities and expectation of the system to deliver stuff. And I should just say that the North East London CCG governing body meets for the first time tomorrow. So they're sort of getting going on the 1st of April tomorrow afternoon. There's more quite development session, but there's a bit of work, a bit of an agenda as well. So again, it just illustrates these things are starting to move on.
Thank you. Thanks, Mark. Thanks, Tracey. Now, my screen's slightly freezing, but any members, I think I saw Councillor David just doing a clap sign to say thank you to Tracey. Any members for a very quick question, Councillor Snell? We make it very quick, please, for nearly out of time.
Well, thank you so much, Tracey. It's just wonderful to have people we're used to coming back. Can you hear me? Okay. It's wonderful to have the people we're used to talking to us about the future, which gives us trust. I'm not sure what page it's on, but I'm looking at transition of subcommittees, and I read down through what you supplied us, and I sort of put guaranteed ? Because at the moment it does seem that what we have set in place in City and Hackney is going to be there. But you've admitted yourself further change is possible. And I completely applaud the fact that we're taking the lead to hopefully set an example of best practice that other people will follow. But I mean, let's be blunt about this. All those subcommittees you talked about and the engagement you talked about, how long is that going to last? How I mean, can you predict it? I don't think it's an unfair question. Sorry, but.
I mean, of course, of course, it's difficult to predict, and what we don't know, what we don't quite know, is how we are going to be expected to react to some of the changes that are going to come through the legislation as well, and what demands are going to be made centrally. I think just the point I keep trying to make is that people gravitate towards the structure quite a lot, and one of the two things I worry about is, one, us not dropping anything, and two, us making sure that we're learning as we go along and accepting that you couldn't prescribe perfection from the outset, because otherwise you wouldn't be learning. So for people to be slightly more accepting and relaxed of that, as opposed to see that as a failure from what we've established from the outset. I think it would be positive if we refine it, to be honest. And I think if we can simplify it, and particularly simplify it in the sense of also how we work as a system, I think that would be really, really good. And although I've talked I mean, I keep saying this is a journey, and when I say it's a journey, I don't mean it's a journey over the next few weeks or few months. I mean, this is quite a big shift in how people think. So it's going to be a while, and there are going to be some things that actually we can do very, very quickly, because as we saw within the pandemic, you get people and clinicians and clinical teams together and practitioners together, and you can make some changes quite quickly. It's when you get to some of the thorny issues, as always.
Thanks, Tracey. I am that's a very cool presentation. We're very glad you're in this role, and you're taking the approach you've just outlined in terms of allowing people to explore and make mistakes to learn. That's what thank you very much. I think we'll have more questions as time goes on. I will go minutes. Can I just have that agreed by members, please?
Thank you, Ben.
I've got a freezing screen here, so I can't see. I'll take that as the thing. I haven't been notified of any other business. The work programme.
I think your internet is telling you something about the time.
Yep.
I think I'm cracking up, guys. I think a minute's agreed.
Agreed.
It is. And work programme is as set out. So with that, I'll close the meeting, everyone. Thank you very much. Close the meeting. Thank you.
Good night.
All right, good night.